Everyone. Thank you for joining here. We're going to have Dr. Cohen on here just in a second. Good evening, everyone. Thanks for joining us. We're going to get Dr. Cohen on here in a moment. Let's see if we can find him. There he is. All righty. He's connecting. Good evening, everyone. Thanks for joining us. There he is.
What's happening, buddy?
How are you? He's got his big blue hat on.
Fantastic. I figured I'd wear this hat just for you.
Amazing blue. I like it. Thank you for joining us tonight. I appreciate it. I know you are a busy man. We really, really appreciate you.
My pleasure. It's nice to be here.
Absolutely. I know this is probably the 20,000th Instagram Live and webinar you've done. So
no, actually, I'm kind of new at this. I've only done a handful of them.
Well, you're getting really good at them. The last time I saw you on one, you were kicking butt. So thanks Ken for joining us.
Thanks.
For everyone, my name is Mike Van Lenton. I'm the regional manager for the Ohio Valley region, which includes Indiana, Michigan, West Virginia, and Ohio. And on with me is board certified dermatologist Dr. Joule Cohen of About Skin Dermatology in Denver, Colorado. And we are so honored to have him, and we're gonna do a little chat. I know you don't have too long, but I wanted to welcome you and ask you an important thing. I saw on your social media the other day that you and your daughter had a fun outing, 4D. Can you explain that?
I sure can. Well, first of all, I have a 7-year-old daughter, I have a 12-year-old son, and I have a 16-year-old daughter. So they're all dealing with this very differently, but my wife and I found a little note that my 7-year-old wrote that said, "Life was perfect before the corona." So I decided to take her up to the mountains now that we can go up there. So we had a 4D field trip, which is daddy, daughter, doll, and dog. So we went hiking up in Summit County, and there's a picture of her holding her American Girl doll. And I had literally the night before just pierced, and I put on Instagram all the earrings, all the ears of all her American Girl dolls and all her dolls. So I took a 18 gauge needle and I had a video of it, and it was hysterical, and she commented on it. So we had a great daddy-daughter day up there, and the dog came, and of course the dog was with us the whole time.
That's awesome. Girl dad, hashtag girl dad. That's awesome. Yeah, my younger son, or my older son, excuse me, is 4. He's just so anxious to get to the zoo, and we call the corona the germies. He just keeps asking, when can the germies go away? So it's tough for kids to understand this, but it sounds like you guys had a fun time.
We did. It was nice. It was definitely good bonding time. But honestly, I've had a special relationship with each of my kids during this whole stay at home. So I've done, as probably you've done, just various things with the kids, from watching a particular show to even going for a bike ride with a mask on.
That's awesome. Well, they do call you Safety Joel. What type of precautions do you take when you go hiking? And it is Skin Cancer Awareness Month, by the way. So what sort of precautions do you take with your kids?
You must have been talking to Matthew Gelber from Sciton, who's the EMEA director for Europe, yes. Middle East. So, well, first of all, yes, that is one of my nicknames. It stems from my wife and one of my good friends here, who's radiologist, and I always sort of see the potential problem in something and say, gosh, we need to do this to protect ourselves. So from a hiking perspective, we wore wide brim hats, we wore lots of sunscreen, we're wearing sunglasses, we reapplied after 2 hours, and we had water with us, etc. I was actually kind of worried about bears, because really there's nobody out there hiking. So I had a hiking pole with me, but no gun, and just the hiking pole. So if we ran into problems, it would have been a problem.
You need to take our mountain guide, Ryan Fueling, our Denver rep, with you. He's got a whole arsenal.
Yeah. Honestly, when you're hiking, probably a .45 caliber is the one to take for those bears. Just the average 9mm might not actually slow that bear down.
Yeah, he's got quite the arsenal. You'll have to talk to him about that. But so you got the big blue hat on, maize and gold, maize and blue. What's your connection to the Midwest? Tell the audience and folks.
So I grew up in metropolitan Detroit. My wife did as well. And my wife went to undergrad med school and residency at University of Michigan. I went for part of undergrad. So we are a very big Michigan family, even though we live in Colorado. And every summer we go to University of Michigan's family camp up in northern Michigan, where I've spent a little time with you outside of Traverse City. And it is absolute utopia up there.
It's beautiful. Now, do you get back often besides the summer thing? Do you like coming back to snow ski at all?
Honestly, I love to get back there for number one, hockey. So to get to a Red Wings game and to get to a University of Michigan football game and or hockey game. And I actually call it a daily trifecta and if it happens where I have a daily trifecta and then I get icing on the cake the next day, I'll explain. So basically we try to go back. University of Michigan, if we can catch a football game in the morning, then we get online to go to Zingerman's, the deli, in the afternoon.
Ann Arbor, yeah.
And then we go to a Michigan hockey game that night. That's the Michigan trifecta for me. But it's only superseded by icing on the cake, which is being able to catch a Red Wings game in the afternoon on Sunday. So it's like a 1 o'clock game, ends at like 4, and we take like a 7 o'clock flight back to Denver, and the 2 hours helps us. That's the only way you can beat a Michigan trifecta.
That's a full agenda. Jesus. So you came into the Sciton family, just to shift gears. You came into the Sciton family about the same time I joined Sciton in 2008. What drew you to Sciton? How did you get introduced to Sciton? And from what I believe, we were courting you for a while. Trying to go steady with you. What made you finally accept our proposal
Honestly,
to dance?
I'm honored to be a Sciton customer because I think really it has been a wonderful laser platform for me since the early days of 2008. So first of all, I did my fellowship at a time in 2000 to 2001 where we were doing a fair amount of full field CO2 resurfacing, and it was within really 2 or 3 years of that we started to see some of the effects of the delayed pigment loss and the depigmentation of areas like around the mouth and eyes. And, that actually really imprinted on me, and I wanted to see great results. And when I started using ablative fractional lasers, I saw great results in areas, but I didn't see it around the mouth and around the eyes. And I really felt that I needed a way to actually be able to more aggressively resurface those areas that have more etched lines and pick the right tool for the job. And in my mind, that was erbium. And I had long discussions with your founders, Jim Hobart and Dan Negus, about really how these work, and Rick Menifee and Doug Caro, and the engineers that are building these systems. And they assured me, and I spoke to Jason Posner and Jay Burns and Susie Kilmer and Vic Ross, that the experience with erbium was different because number one, you could recognize your endpoint and pinpoint bleeding. Number two, the water binding absorption was 15 times more efficient. And number three, you weren't putting as much heat into the epidermis. It was really dispersing itself between the epidermis and dermis. And I looked at these results for some of these people that took me under their wing, and they were really impressive. So I started to do full field erbium resurfacing mouth and eyes back then. And I still do it. And I still do it very similar to how I did it before. And I think that's how to deliver great results. And, you guys have been really kind in allowing me to be one of the preceptors and to teach other people how to do it. I've published on it. It's something that I do a lot of. And it's really gratifying to give people one trip into the office and really heavily resurface around the mouth and eyes using full field. And then I may use kind of a combination of profractional on the rest of the face with some micro laser peel or with some, more moderate resurfacing that I would use around the mouth.
Now I've heard you mention a analogy, and I'll give you credit for this one plug, where you can do combination therapies. Is that something that drew you to Sciton, where, you have multiple clubs in your bag, so to speak, to use a golf analogy?
You know, honestly, it's a great analogy. So I think one plug becomes important when people are out there and somebody may be graduating residency or graduating fellowship, or they may be a plastic surgeon or dermatologist looking to get into laser. You know, the question is, are you going to buy a couple different systems and really, you know, have something for resurfacing and have something for vascular and have something for pigment, you know, and something for hair removal? Or are you going to try to find a platform that really works well? And, you know, so you have to think about overall economics of things and the resources. You have to think about the versatility of the system, but you also have to think about that 220 plug. You know, typically not every room has a 220. You have to retrofit a room. It's about $2,000 every time you do that. And, you know, it's not something where when we're building out spaces, we're really thinking, you know, gosh, I might have 2 or 3 lasers in here. I'm going to have a couple 220s. So I think this really, that one plug philosophy allows us to really address this. So I use the Sciton Joule platform in terms of heavy resurfacing with full field. I use it for profractional. I use it for single shot erbium, which I use on macular seborrheic keratoses and sebaceous hyperplasia and xanthelasma and syringoma. And then I use it for actinic cheilitis. And then just switching gears, you know, I use it for halo. And then also that other arm piece in terms of BBL and treating, you know, and treating lentiginous and treating some areas of vascular. Now you guys have clear V. So I think really you address everything.
Great answer. You mentioned your fellowship before with Doctors Carruthers. How did you get introduced to them, and did you have exposure to lasers during your fellowship?
So, you know, first, when I trained in my residency, there was somebody 2 years ahead of me that did their Mohs College fellowship with the Carruthers. So many people don't know that Alistair Carruthers was a Mohs surgeon for many years, trained with Stedman, and is a beautiful surgeon. So having the opportunity to do a Mohs College fellowship and be with some great surgeons and spend time with the Carruthers on a regular basis was truly an exceptional experience for me. And also within that particular fellowship, on a regular basis every week, I spent time with Jason Rivers, who really has become, you know, a cosmetic superstar at this point. I learned a lot of lasers and injectables from Jason Rivers, as well as Harvey Louie, who was the chairman at that point and is a well-known person in terms of lasers and photodynamic therapy. So yes, we did a lot of lasers in my fellowship.
Now, you're probably one of the most widely published what got you so interested in research and publishing? Was it your fellowship? And can you recall which article or study are you most proud of, and where you think had the most impact?
Well, first of all, I just hit 250 publications, and then I have 3 textbooks that I've co-authored. So I really do like to write, and I think some of that stems from the fact that I was a history major. So I really, you know, telling a story, whether it's, you know, a review article and saying the origins of this procedure is this, and these other people credited have pioneering it, and this is what it's evolved to, you know, or a study where we're actually chronologically looking at people prospectively. And then, you know, from a math perspective, I wasn't a math major, but it was something that I always, you know, had an affinity to. And I think it's interesting to really design a study well and think about the methodology and think about if you're really comparing things adequately. So I think those 2 opportunities, telling a story and looking at the has gotten me, you know, interested in these types of things, and I enjoy it. So I have the opportunity to be on the teaching faculty at University of California, Irvine, in Chris Zachary's department with Kristen Kelly and Patrick Lee and a whole cohort of other people. And, you know, being involved with the residents and resident teaching and getting them excited about doing things and using the technology that they may already have, you know, in their clinic is really fun. And I've done a number of writing projects just because I was curious about things. We've published several articles in terms of the emergency kits that we need in our office. We just published in Derm Surge based on something that I wanted to start, and we wrote up. We have an article in press about a chlorhexidine review article. We have an article about laser plumes. And then we have an article about skin cancer margins and things like that, and a couple case reports that are actually coming out soon. So I think just that whole inquisitiveness is something really, that's always been there for me.
Yeah, some incredible work, and I cite a lot of your work often. It's hard to do on Instagram Live, but I wanted to show you a case that you published. And could you walk me through this gal? And you were mentioning full field erbium before, and this as an example. This is one of probably the deepest perioral lines I've seen in my career. Walk me through how you approach this case, and we can talk a little bit about the settings.
So that article comes from a Journal of Drugs and Dermatology article I published just a few years ago. It was a single author. And I really talked about the way that I approach a patient with heavy, heavy etched in lines. Because if you look at those lines, and unfortunately just with the flip of Instagram, the before is on the right and the after is on the left.
Right.
And just flip it. In Hebrew, people read right to left. So just maybe read that way. But, so the before is super etched in lines. And if you look, that orange peel texture, that solar elastosis, those imprinted lines, there's no way that you're going to be able to take a filler and put it into those lines individually and see a really impressive result. And there's no way, in my mind, that you can take a fractional device and in one treatment give them a very impressive type of improvement. And even in this particular patient, I would quote them probably at least 2 treatments because the photo damage and the etching is so bad. But, around the mouth, I don't use coag. I tend to do 100 microns, sometimes 150 microns per pass. I numb them up with a local, I do an infraorbital block, a mental block, and then I do what I call a sulcus block, and I go around the mouth. So really, they feel some vibration, they feel some heat, they don't feel pain. And because my local is lidocaine plain and not lidocaine with epinephrine, I actually feel like I can see that pinpoint bleeding a little bit more effectively. So, I think this is my approach. This is a pretty common patient that I see, and I'm grateful to people like Jay Burns and Jason Posner who really showed me years ago how to do this, and now I have the opportunity to show other people, because ultimately people want results. And sometimes people come in for modest procedures, and sometimes people come in and say, this is what really bothers me. I've got this heavy etched lines. I've been a smoker for many years, and we've got to do something about it. And I think the Sciton Joule platform is the right tool for the job.
Awesome. Now, what is your endpoint? In this, your 3 passes of 150 microns, so it's additive. What are you looking for as you're doing those passes?
Well, first, I don't cover the entire area 150 micron times 3 necessarily. Like sometimes I'll do 150, 150, and then I'll go down to 100, and I'll start looking at more etching. And then you can see, some of the lines that are pretty deep, more medially. So, and then I also taper it down to 50 microns, and I change the spot from like a 4 or 5 down to a 2 or a 3, and I just work on an individual line. So whenever somebody asks you their settings, in particular the upper lip, it should always be a range. It should be, I treated majority of the lip with about 400, 450 microns, and then I started to go after those individual areas where I could still see the line. And it's at that point that you start to see that pinpoint bleeding popping up through there, and then you wipe away, you still see if you see the line, and you get a sense when you see a little bit more than pinpoint bleeding, it's time to actually halt back. And then I will say it's important to treat the entire upper lip. You don't want to treat these areas towards the vermilion more aggressively and then have these areas above it not as treated as much. So really you can taper your settings, but you want to go all the way up through the entire cutaneous upper lip.
You mentioned actinic cheilitis before, so don't necessarily be afraid of treating over the vermilion border.
So actinic cheilitis is typically something we see on the lower lip. That means it's something where people have whitish sort of changes. If you feel it, there's no bumpiness, there's no skin breakdown. Otherwise, you have to biopsy it and make sure it's not a squamous cell. But if it's that whitish hyperkeratotic change where you've lost the color, the red color of the lip, and you've lost the demarcation, then yeah, it's great to use full field Sciton erbium resurfacing over that area. And I actually think that's a great area where people learn to actually appreciate the endpoints. Because when I treat actinic cheilitis, I use 50 microns, no coag, and I'm usually going 5 times, sometimes 6 times, and it's bleeding at that point, and that's the endpoint that you're looking for, and that really tells you to recognize your endpoint. So that's good practice in a very forgiving area like the lower lip to getting to the upper lip where you're actually treating these more etched lines.
Now, do you find if someone has a lot of deep etching lines around their mouth, do you like to feather out with halo or profractional on their cheeks and the rest of their face so you have an even tone?
You know, so I'm seeing some friends just joined on. Josh Eichner, hey Josh. So, so you know, I do a lot of feathering. So if I'm at 100 microns and I'm going around and I'm doing it a few times here, then I may attenuate it as I get towards the areas of the secondary smile lines. This oftentimes still needs 100 microns, and then you may go to like 80 and then 60 and then maybe 50 and feather out. But I also throw in a fair amount of profractional, but I turn the coag up to 3. And I think that's what helps with hemostasis. And there's a lot of things that you can do to help with hemostasis because, again, this is lidocaine that's plain. There's no epinephrine in it. And that's really, you know, the way that we actually approach this. So I think that, you know, in terms of an area, like if I'm treating rhinophyma on the nose with Sciton full field erbium resurfacing plus profractional, that coag 3 really helps get some hemostasis, but I might actually take some 20%, 25% TCA, and I'll just go over another area, which TCA, many people don't realize, actually helps with hemostasis. And there's an article that I co-authored in Dermatologic Surgery with Dave Ozog and some other folks just in February looking at hemostatic type of agents. And it was an article, 2 articles that I proposed, one looking at the new anticoagulants that patients are on and the mechanism of action, and secondly, looking at hemostasis. And they're both in that issue, but it's really helpful to actually think about what can help you with hemostasis. You can do pressure. Sometimes people actually take a little bit of lidocaine with epinephrine and squirt it over an area like rhinophyma after doing that type of repair. But, you know, when you're getting down deep into a lobule and a bulbous type of nose with rhinophyma, you're going to encounter bleeding, and it's helpful to apply pressure and have some ways to actually stop some of that.
And as you mentioned, adding coag. So essentially you're mimicking the histology of the CO2 laser with using the tunability of the Sciton, correct?
Correct. So you can, with the profractional, you can turn it from coag 1, coag 2, coag 3, and that emulates really CO2.
Now, are there areas around the face that you think coag is more beneficial? Like you mentioned, the cheeks. What about scars?
You know, typically it depends on someone's skin type. If somebody's really fair complected, you know, I will add some more coag into it. But if somebody is darker skin, you know, type 4 or for sure type 5 skin, I'll dial back on the coag. And I haven't really seen issues related to erbium because I think it's very different. I think erbium is much safer in darker skin types, especially when you get to full field erbium. And I've used it for acne scars in type 4 and 5 for a long time, and even some areas in type 6. But I think we just dial back the coag. So, Mike, I'm sorry, I got to run.
You got to hop.
But it's really good to talk to you, buddy.
Yeah, absolutely. Thank you so much for joining us. So we got to cut it a little short. We got it started a little bit late, but thank you, everyone. Dr. Cohen, it's always a pleasure. Thank you for sharing a lot of pearls and wisdom. And most of all, thank you for being a member of the Sciton family. We really appreciate you.
Thank you. It's an honor, and I love my Sciton devices. And we didn't get a chance to talk about Halo, but Vic Ross and I published the first article in JDD about combining non-ablative and ablative fractional together. And it was really a study looking at the old Palomar technology. Yeah. And if you look at the white paper on Halo, it's the reference in there in terms of the origins. And it's been exciting to be involved with Halo, and it's been exciting to be part of some of the protocols and then even some of the newer software and things like that. And I want to mention that for Sciton, it's a really exciting time. And the Joule Moxie, you know, the 1927 wavelength laser is something that, you know, some of our patients who don't want downtime right now may be interested in doing. And there's, you know, other lasers and other technologies out there that are 1927. This actually also has the approval for actinic keratoses as well. So we'll leave it at that, bud.